Okay, folks, I've turned the camera on again. Oh, not the camera. The recording again. I've got to learn the difference in these things. Okay, a quick run through the evidence. Fortunately, this is fairly straightforward compared to a lot of other disorders. Firstly, have a look at your NICE guidelines, which give you an idea and all the stats. If you go deep enough, the NICE guidelines are a fantastic resource based on a huge amount of nerdery. You need genuine nerds to create something like those. I served on the 2017 panel. I can tell you, I was just one of the least nerdy people there, and that's saying something. And there you've got the evidence about a range of guidelines. Also, the Academy for Eating Disorders has a summary taken from about psychological therapies only. It comes from a whole range of international guidelines, including the NICE one. They say fairly similar things. The AD version is probably a little simpler to follow. Broadly speaking, what's the evidence about treatment of eating disorders? There's pretty much no evidence that NICE will consider for drugs. SSRIs will give some relief from binge frequency, but not a huge amount. It doesn't stay away. No other medications have got enough evidence to make it NICE guidance. It doesn't stop clinicians trying. You still hear some really weird medications being tried out, but at the moment, the evidence isn't there. They recommend that intensive treatment, so inpatient, day patient, should only be used long enough to get the person well enough that they can then use outpatient psychological therapies. And all the evidence that there is does sit with those psychotherapies. Again, as covered by the AD guidelines. So what does that guideline say? Well, there are some, I'm going to sound like I'm being very kind of petty here, but there are some second level therapies, ones that will have some effect that might be worth trying if the main ones don't work. Things like DBT, cognitive analytic therapy, interpersonal therapy, and others. But the three big ones to be aware of: CBT, Mantra, SSCM, and probably most of your services operate at least a couple of those. What we're terrible about, though, is treatment matching. Yeah, we know if you've got a kind of normal weight or above, then CBT is the therapy to go for. We know that if you're younger, try FBT, but if it doesn't work, then bring in something else like CBT is a good next thought, and make changes early rather than going on forever. But there's not a lot else that we do know about what therapies will work for which kind of people. So this is the list of recommendations for the different children, adolescents, and adults by which disorder they've got. There is more recent evidence since this came out about CBT for ARFID and for OSFED, the atypical cases. So this, again, is always going out of date because of the nerds who keep coming up with new evidence. The evidence also says they work fine in routine settings. This isn't just stuff that says, oh, it works in a research lab. This will work in your clinic. It'll work where you are. The effects don't disappear just because you live in a different part of the country. We also know that the effects of working with the eating disorder have knock-on effects on other problems, as I say, or have a knock-on effect on your anxiety, depression, etc. And we know critically, early change is your best predictor. If you want to know what will best predict who's going to do well, it's not how old they are. It's not whether they've got a severe and enduring problem. It's not whether they're depressed. It's not whether they've got personality disorder diagnosis. It's how quickly can you get them to change their behavior in the first 4 to 6 sessions. We also know that severe and enduring eating disorders, which I'll put in inverted commas because I don't really understand the label, actually respond pretty well to effective treatments. In other words, there's plenty of evidence now that it comes from Australia, from the UK, from Italy, that however long you've had the problem, however severe it is, if you give them CBT, it's got a good chance of working. There's similar kind of evidence coming through about FBT for young cases as well. We also, though, the clinicians often miss bits of the sort of therapy. So as you go through this next couple of years, or next couple of months rather, you'll start picking up that there are things where you said, okay, we do CBT, and you'll be looking at it going, but we don't do that bit. There's so often we hear people who say we don't weigh the patient, we don't have a mirror to do mirror work, or we don't do exposure work. We want to get you doing CBT treatment disorders effectively. So if we violate a few of your beliefs, don't panic about it. You're certainly not going to be the first person we've ever done that for. So our job here is to get you good at it, not to expect you to be good from the beginning. That's what we're here for. So again, ticking off my little bits and pieces, gone through knowledge of eating disorders. I'm now going to work on that final one, assessment. If there are questions about it, again, please do interrupt me. Anything to stop me talking. I call this assessment engagement because they tie together so well. How well you assess the patient will have a big effect on whether that patient is going to come back. Do they believe that you understand them? Do they trust you? Do they think you're a nice enough person? Do they believe that what you're suggesting is not just scary, but also has potential to transform their life? That's what we're looking for. So are our patients that different? I'm not going to go into a discussion here. We started off too late for that one. But it is important to think how I'm assessing this person will have a big impact. So again, what are the big aims? The stuff I'd like to see in a case report, for example. Has this person got an eating disorder? What would be the most appropriate treatment for that person, given the nature of their problem? Are they ready to change? And if not, can we help them to consider making change? And are we checking out risk? All of this is about making sure the person who comes to see you as the therapist is a good case for you to be seen. Because if it turns out the person is way too risky, then that should be what's addressed. If it turns out that they don't actually have an eating disorder, why are they coming to you? So when it comes to what we're going to ask about, we quite like using checklists. We've got one that we put up on the website. Fairburn's got one as well. And these are checklists that keep us on track. But checklists shouldn't be question 1, question 2, question 3. It should be question 1, question 8. That leads us to question 5. That will take us back to question 2. So you use it to remind you what you need to ask about, not to tell you what to ask in what order. The way that we do, the questions we ask, the way the patient responds is going to tell us a lot, a real lot. So think about not just what answers the patient gives, but what is their, if you like, the process by which they give the answer. What are the clues that you can see in the room? Is there somebody else there who's filling in the information for them, or somebody who's only just there to support them? All of these things mean something. So, for example, assessment session number 1, I'm watching the patient to see what they do in terms of their body image. Now, I'm not going to touch body image in therapy until way later, but I want to be able to say in my report, I think this person has got this problem, and that might be worth coming back to. So, for example, person who comes in dressed in big baggy clothes in the middle of the summer, I'm going to ask them questions about whether you routinely avoid looking at their body, because that will tell me what I might need to be doing later on. If they ask me, do you think I look too fat? I'm going to be thinking, it might be they're doing a bit of mind reading here, or they're doing a bit of comparison. So these are things I'm going to be looking at and making note about, not because I know the definitive answer, but I want to give a clue later on. I'm going to look at the person's eating. Their restriction, for example, how much do they say they eat? I always send out food diaries before the first assessment session, because that is so helpful in getting an idea of what the patient actually eats. Our self-report is pretty terrible about this stuff. But are there patterns of eating? Does the person never eat anything before midday? Do they only eat particular types of food, etc.? Or they only eat very, very small amounts or very large amounts? What's their alcohol intake? What are the rules of eating for them? And remember, these are safety behaviors. They're ways of making yourself feel safer in the short term. They may end up being a disaster, but they make you feel better in the short term. I'm going to be asking about binging. When the person says, I binge, give me an example. What's the most recent binge you had? What did you eat? How long did it take you? How did you feel about it? And sometimes what the patient will say is, I ate 2 biscuits. And I'm going to be thinking that's more what we call a subjective binge. You feel out of control, but the amount you eat isn't that huge. And that's why, for example, your weight isn't going up. Or why it's so hard to vomit, because that amount of food isn't going to make a big difference. It's still important. It tells us something about the psychopathology. But it doesn't mean that we then have to say, okay, we've got to completely change your diet. And then we've got purging behaviors. How often do you vomit? You make yourself sick. Do you take laxatives? I want to know if they take laxatives, because I want to be able to hand them a psychoeducation sheet at the end of that session saying laxatives essentially don't work as a means of weight loss. I want to be able to tell the patient that one so that they're clear that actually some of what they're doing isn't going to be very helpful. And then, of course, I chucked this in the last minute, semaglutides. How many people, just stick your hand up if you're working with people who take semaglutides or have taken them. Okay, so a few of you have, but not, oh no, actually quite a few of you have. That's okay, that's great, thank you. Hands can go down, all that sort of thing. People have got really panicky in our field about semaglutides. What can I do? What can I do? This comes up in supervision a lot. What I say is, well, imagine that this was a diet pill 10 years ago. Imagine this is the person who a couple of years ago would have been, vomiting, etc. If the person wants to lose weight and they prioritize that over doing effective therapy, fine. But we can't actually do effective therapy with somebody who's currently taking semaglutide. So it's up to them. If they prioritize the weight loss, then what we usually have to say to them is, okay, once you run out of money to pay for this stuff, you're probably going to find the binging comes straight back. All the evidence at the moment is the weight gain, they regain weight and the binging comes back. Or they regain the weight even if they weren't binging. So my favorite is usually say, okay, why don't you try doing it this way? For a couple of weeks or even a month, try doing the weight loss thing that you're trying to do. Then come off the medication and see if it sustains. If it does, you've broken the normal pattern, good for you, well done. If it doesn't, you end up eating all over again. Then all you're doing right now is holding off on the binging by wrecking your appetite. At that point, we might be able to do something, but we won't be able to do it if you carry on taking the medication. So drop the medication. Obviously, if there's a reason, a real reason to take the medication, like weight loss is needed before, for example, diabetes gets them, then you're dealing with life-threatening stuff, and you deal with that before you do the therapy. So we've had patients who, for years, have been told you've got to lose a very large amount of weight very quickly. We can't help them with losing weight, but we can be there to deal with any consequences, like they end up binging in a couple of months' time. Helen, you put your hand up. Sorry.
Yeah, while you're talking, I tried to do a quick search on Google about it. Is Mounjaro a semaglutide?
It's a related drug, but it's not actually a semaglutide from what I understand. It's only come into the literature for me in the last or in fact, I think it's only come into the media for me in the last maybe 4 weeks. There was some kind of case that was involving, I can't remember what it was. So it seems to be related to semaglutides. Essentially, there is a big industry in Denmark pumping this stuff out right now. And I think that's going to be how they avoid trading Greenland with Donald Trump, from the sound of it. But this seems to be what's going on with their kind of sudden interest in weight loss medication. Trudy.
I just read an article yesterday that was talking about these new issues that have been erased from that have come up with the semaglutide. I don't think that Mounjaro is a semaglutide. I don't think that's the ingredients in it.
Yeah, I mean, I don't know if other people have noticed, but I saw this TV adverts, for example, Suddenly, there's a whole bunch of TV adverts around orlistat, semaglutides, etc., where it's being portrayed as, we're going to help you lose weight through a customized process. I cannot begin to think how much money that people are paying for this stuff. But the fact you put it out immediately after Christmas is probably no great coincidence. But the same thing is going to apply, whether it's semaglutide or not. If the patient is so determined that they're going to do it this way, then be prepared to back off and say, let's see whether you're right. Rather than panicking about which so many clinicians are. Anyway, back to where I was. I want to know what their weight is. If you come to me saying, I didn't weigh them because they were worried about being weighed, I'd say to you, then you don't know enough to be able to work out what to do with this patient. Certainly, there's not an evidence-based treatment that doesn't involve weighing the patient and telling what their weight is. So weight is going to be a really important one. And when I talk about CBT-T and also CBT-E, we aim to crack that from session 1. We ask about body-related behaviors, as I say, things like, do they check, do they compare, are they doing mind reading, reassurance seeking about their body, etc. And then issues like the felt sense of the body dissatisfaction. I always, in session number 1, ask the patient to estimate the size of their waist. Normally, they go way, way bigger than it actually is. If I'm doing it online, we do it with some bits of blue tack that we stick on the wall, and then we get the patient to stand between the bits of blue tack, etc., and put more blue tack on to show just how far out they are. Why do that in session 1? Because I want that patient going, oh, maybe all these assumptions I've got aren't completely correct. Basically, I'm trying to rattle the cage of some of these beliefs very early on. I want to know about what we call the broken cognitive link, that fear that whatever I eat, my weight will shoot up out of control. Does the patient experience that? Most people will, apart from those with ARFID. And I want to know about fear of fatness. What is the person worried about? Is it about their shape? Is it about their weight? Is it about their eating pattern? Again, plenty of measures you can use here on the website, EDEQ, ED15, but there are other ones out there. There's a couple I wouldn't recommend, but that's for reasons nothing to do with what we're talking about here. But again, get the measures. And when it comes to things like case reports and supervision, have those on that little spreadsheet that Rachel was talking about earlier on. Comorbidity. I want to know from the assessment what this patient has got. You know, are they depressed? Are they anxious? Again, routine measures will help you out hugely here. What impulsive behaviors do they use? What kind of personality pathology? Whether you think it's a personality disorder or not, it's that pattern of personality pathology. It may not be accurate. Think about the number of patients you see on their first session and they're emotionally all over the place. And they've already got a label of emotionally unstable personality disorder. I challenge you to try not eating for the next, or let's say 48 hours, and not to go a bit emotionally cuckoo. You know, well, welcome to the wonderful wacky world of serotonin. Again, more about that later on in the year. But personality pathology I want to know about because that's how the person's facing the world. Physical assessment, I want weight and height. Weight for height by age in children and adolescents, BMI in adults. Again, these self-reports, if the patient is telling you this online, I want that patient in to at least measure their weight and height once, because pretty much everybody overestimates their height. Oh, sorry. Yeah, pretty much everybody overestimates their height, underestimates their weight when you ask them to give those estimates compared to what they actually weigh and what their actual height is. So it may be that your patient is not as thin or not as large as they are saying. And of course, we want to be sure that body weight isn't being falsified, no water loading, no carrying of weights. We have one patient who managed to, I remember everybody in the staff room just being sitting there going, what the hell just happened? Because the patient managed to falsify their weight by something like 4 kilos by water loading, carrying weights, etc. And let's say they weren't carrying the weights very obviously. That's plenty enough for me. Weight trajectory. is going to be really important. If the patient is generally stable, keep an eye on if their weight shooting up, shooting down. That can be as important as their actual weight at the time. Claire, yes, go for it.
Sorry, I just wanted to ask, how important is regular weight monitoring in binge eating disorder?
Very, if you want to explain to the patient what the binging is doing.
Right.
Because what you'll say to the patient is, I want you to eat, say, 2,000 calories a day. They will panic because in their head, they're trying to avoid eating anything. Now, they're probably eating 3,000 calories when they binge on lots of food. So they're gaining weight because they're getting too many calories per day. What I want to do is persuade them that actually if they eat just 2,000, the binge goes away, their weight will probably even fall. It's amazing how many of our patients have a fall in weight when we're not trying to get them to, we're just trying to get them to eat regularly. I want that patient learning that regular eating is a good thing. Does that make sense, Claire?
Yeah, perfect. Thank you.
Yes. I also want to know about muscular strength. I want to know about cardiac dysfunction, actualized bone density, all the stuff I talked about earlier on. And again, if you can't do this stuff, and I have no reason to think you can take bloods, etc., then make sure you get the person who can do so to do it. I've never done a bone scan in my life. They're quite fun to look at, but I rely on the person who knows how to read them to get the information. But this goes back to the risk factors I was talking about earlier on. Wave me then, Laura.
Sorry, Glenn, your microphone is crackling really badly and we're struggling to hear.
Okay, is that any better?
No, there's a whole lot of feedback as well when other people ask questions.
Okay, can people make sure they've got their microphones turned off? Because that's normally the problem. I'll keep rambling on, and if there's any bits of this last 5 minutes that you miss, wave me. I'm sorry, I'll have to get you to go back and go back and listen to the recording. And was it Laura who had her hand up as well?
That's why I had my hand up, Glenn, just about the noise.
Got it. Sorry about that. Okay, I'll lean in closer to the microphone in the hope that will do something, but I'm not quite sure what. Again, related to what I said before, I want to know about other risk factors, but some of them are going to be about the family, general development history, trauma history, etc. What are the client's motivation and goals for treatment? Do they think the treatment could work for them? That's really, really important. And then in particular, what therapy have they had before? Did it work? If it didn't work, why not? And sometimes you'll hear people say, I've had CBT, and you listen to what the patient tells you went on, and you think that's not CBT. Other times, you hear patients who come up with therapies which, honestly, you've got no idea what the heck they were meant to be. My favorite, to give you an example, and this is a warning, don't be this person. My favorite was a patient who said to me, well, my previous therapist said that the only way I could get better, because I've got this history of trauma and bulimia nervosa, the only way I can get better is to be bounced up and down his knee while I talk about the trauma. Now, I don't know any therapy that looks anything like that. But you then got to remember that patient didn't know that. From her point of view, that was, oh, so that's the right treatment, is it? All right, I'll do that. I think it gave her a shock when I wasn't actually going to bounce her up and down on my knee. And I really didn't, I promise you. Yep, Amanda. Your microphone's off, Amanda.
The feedback's really, really distracting, Glenn. You sound like Darth Vader.
Oh, it's a way big. Okay, I'll log off and log back on again for the last couple of minutes, okay?
Thank you.
Okay, is that any better? Okay, sorry, I have no idea what was going on there. I'm not Darth Vader, in case anyone's still scared about that. Let me just put up my slides. Sorry about that. I've got about a minute's worth of whittering at you to do, and then we'll be done for the day. Oh, if the dog will allow me. Okay, so the last bit I want to do is, are you acting in a collaborative way? If you're explaining the treatment options appropriately, if you're assessing the patient in a way that's curious and prepared to explain stuff to the patient, if you're giving the patient enough detail about the treatment options so they can make a meaningful choice and comparing it to any previous treatments, you're giving the patient a reasonable expectation. They may or may not want to do the therapy. They may not come wanting to do therapy at all, but it gives you the best possible chance that you'll engage in the therapy that they will take part in. That's the key thing that we're looking for here. We want them to have the best possible chance, even if they decide not to engage. And then what we want from you is that positive stance. What would be the benefit of the therapy if the patient engages in it? What would be the limitations? What would you not expect, like weight loss, for example? I'd always say to the patient, I'm not going to guarantee you weight loss because that could happen. It might not happen, but we're not going to aim for it because that will keep you in the problem. And then what's scary about the intervention? Exposure, changing your diet, changing the way you interact with other people. They're all scary for the patient. What I want you to be able to do in an assessment is to be able to say, is that patient going to really engage in the treatment, even though they agree to it? Are they doing it because the doctor's told them they've got to come? Or are they doing it because they're intrigued and they think, oh, there's a real possibility here? So what we want to do is deal with any non-concordance, as in, oh, but I thought you were just going to help me lose weight. You need to deal with that one by being honest with the patient about, it's not what we can do, but there are so many things that we can do to help you. Right. I'm going to stop at that point. I'm sorry we started a bit late, as you know, and apparently I do sound like Darth Vader, which is quite possible. But I'm going to stop at that point and say you've now got a lunch break of 43 minutes, and then it'll be SPSR groups. So we'll see you back there for those. I don't want to delay your lunch anymore. If you do have other questions, you can always email them to me. Okay. Right. You'll see more of this stuff later on with the role plays that we do as well.
Thank you.